Good afternoon, everyone. Thank you for joining us today. Today we're joined by Greg and Zach. This is I think, our eighth in our series of 9 CEO CFO topical webinars. Today we're going to be talking about Know Your Value, regional collaboration, and competition. Um, for the folks on the live call, we are a small group. You feel free to unmute your lines, put anything in the chat. If you're watching this recording, if you have questions or would like more information, please feel free to reach out. We want these to be as informational as possible. So with that said, Greg, I will turn it over to you.
Thanks, Laura. This is Greg Wolf from Wintergreen, and Zach Bozer, my colleague, is going to tag team this with me. I think in terms, Laura, of housekeeping, the next webinar is next week, I believe, next Tuesday.
We
at noon.
actually, next Tuesday is the RHC webinar. I believe the topic's expanding specialty services within clinics. And then next Thursday is our makeup webinar, the PIEC one.
Okay, great, excellent. All righty. Well, let's get started then. For those of you who are not aware, this will be the first of probably 78 promotional notifications. But folks who are on the call, invited to attend the Oklahoma Rural Health Annual Conference in Edmond. This is, as somebody who has the privilege and benefit of going to all kinds of statewide rural health conferences, this is one of the best ones in the country. And so if you don't have that on your calendar yet, I would encourage you to put it on there. And it's really a great conference. You guys are awfully lucky in Oklahoma. Let's talk a little bit about the rural environment and set the table for what we're seeing across the industry, which is a continued integration and aggregation of healthcare provider organizations, vertically integrated, certainly with growing regional aspirations. And what that means for us in rural America is, the 1 in 5 of Americans live in rural areas. And so that is a material, increasingly attractive market for increasingly competitive, urban-centered healthcare organizations and competitors. And we always like to have this presentation and this conversation because we want to make sure that in our rural communities, many of which have a community or critical access hospital, all of which virtually have primary care presence, we want to make sure that we're operating with our eyes open and we're aware of what's going on in terms of industry trends and market consolidation. And really, at the bottom of this, understanding the value that small rural hospitals and rural health clinics, and to a certain extent, freestanding clinics and FQHCs as well, although those are not too dominant in Oklahoma. Understanding the value that you provide your communities and making sure that we are maintaining a healthcare presence that has optimal access and quality. And in doing that, there's all kinds of obstacles and barriers. Coming out of COVID, one of the biggest obstacles we all know is the staffing options, especially around nurses. And inflation and the supply and demand ratio has not been very good to small rural hospitals. And it's really a challenge. And in some ways, it's an advantage that our urban counterparts enjoy and potentially can use that as a competitive cudgel against small rural hospitals and critical access hospitals. One of the things that we see far too often, and candidly, it doesn't seem to be going away at any significant rate of speed, is the misconception, and I know this is a hackneyed phrase, the misconception that rural is just small urban. And repeatedly, we work with really smart, lettered senior leaders of urban-based healthcare systems that really understand healthcare, especially hospital and inpatient-based care, but their understanding of the nuances and the intricacies and the fluidity from a regulatory and a reimbursement standpoint of rural healthcare, it's not very strong. And what happens is all kinds of perversions can occur when large health systems impose on small rural provider organizations their rules and their prices and their policies and their strategies. And there are times when the integration of a small rural hospital to a larger health system can really be a beneficial, terrific thing, but it's almost never quite perfect. And much of the challenge resides with the fact that the key decision makers of the health system really are smart, but don't understand that rural is really quite different than the way urban care is delivered. So for us, we see that as an opportunity less than a threat. And the opportunity is collaborating with regional partners, whether it's simply a referral relationship, which you're required to have as a critical access hospital at least, all the way through the range of management agreements, organic referral patterns, or ownership as part of a large healthcare system. And we're seeing more and more of that. The opportunity is explaining and then implementing the unique regulatory and reimbursement characteristics that have been created specifically for small rural markets. And much of those opportunities translate into primary care, specifically rural health clinics, and how you configure your primary care delivery system in an increasingly value-based care oriented reimbursement environment. And so part of what Zach and I are eager to cover today is how do you take what can appear on the face of it to be significant challenges and barriers and turn them around and actually make them positive characteristics and opportunities for your hospital and for your clinics and for your providers. And then ultimately, of course, for your community. So we talked about some of the challenges that we've been facing. And again, coming out of COVID, probably the biggest challenge that we hear is certainly the one challenge that gets the most airtime and people seem to be wringing their hands the most about are the staffing or the provider shortages, and especially the costs associated with having to pay nurses and keeping them on staff. The cost increases with the inflation. I don't think anybody's inflation or cost, your expense profile is going up by a meager 2.1%, which is the Medicare percentage increase, certainly attached to the RHC Modernization Act. But when you see CMS claim that the expenses, on an annualized basis, are going to go up 2%, I did by almost an order of magnitude. We've not come across a hospital that just has 2% increases. We're seeing more and more competition because what's happening is the larger health systems, they're interested in growing. And in today's reimbursement environment, especially around health reform and population-based reimbursement, growth translates into attributed lives. Attributed lives are associated with or linked to typically primary care practices. And so the competitive environment is getting more intense, and those battlegrounds are really not about the bread and butter inpatient or even some of the ancillary hospital-based services, but instead the competition is around the attributed lives, and therefore the attractive partners for regional healthcare systems that have aspirations to grow into rural markets is really around the primary care delivery system. And then I guess on this slide, the last thing I would offer as a point of color commentary is Zach and I and Jonathan and others at Wintergreen, in our travels around the hustings, we have not come across a critical access hospital or a rural health clinic that absolutely has got all of the revenue cycle issues taken care of. It is a very complex, complicated, constantly changing environment around documentation, coding, and billing. And so the best organizations we work with are the ones that tie revenue cycle to the clinical function, and that they're able to manage their revenue cycle very effectively. And I think that's part of one of the points of appeal potentially of a regional partner. And I say that bi-directionally, meaning the extent to which a hospital and its clinics have a high performing revenue cycle, it makes you very attractive to a regional partner. Conversely, a critical access hospital or a clinic that constantly struggles with revenue cycle issues, your interest in potentially partnering with a highly competent health system that really knows how to manage revenue cycle, I think your interest in aligning with that regional health system will grow, because you want to get access to those skills and those competencies and that infrastructure. So that's the current landscape. And let me finish by saying, when we think about the improvement model in rural markets, the two key nodes at the top, strategy and operations, and this is really from the lens of the rural primary care. And again, because of the attributed lives and the growing instance of value-based care, we really do think about our markets in rural America less so as just a hub and spoke where the hospital is the center point, but it's really much more of a holistic constellation of providers, with increasingly the primary care practices and your advanced practice providers and doctors with the practice in those clinics. We're seeing that as really being the most important component of that delivery system. And it's through the clinics that you can play offense and defense. On the operational side, while we're very much committed to quality, increasingly quality will not exist in isolation, but instead quality will be one of the variables in a complex equation to arrive at value, where value is a function of how well do you provide education, prevention, and chronic disease management services, as well as the outcomes and process measures related to clinical quality, coupled with the ability to provide access to the patients, which will then translate into reimbursement. And so gone are the days of just looking at volumes times payment in a fee-for-service environment. We're seeing this get much more complicated in the future. And part of what complicates that very complex situation that we have is that, for the most part, small rural primary care practices are not particularly sharp at collecting and reporting quality measures. And so we offer credit to some of the advocacy organizations that have proffered and been successful at achieving exemptions for public reporting for rural health clinics specifically. That's great, because it's lifted or disabused clinics of the burden of collecting and reporting those quality measures. But the net effect is we don't have any information about the quality of care that's being provided in those rural practices. And what happens in an information vacuum is typically bad things. And so we see reimbursements getting slashed for provider-based rural health clinics as part of the RHC Modernization Act, at least in part because there was a lack of evidence that our advocates had in their back pocket to make the case that rural health clinics are really delivering value in our rural communities. And so for those of you who have provider-based rural health clinics, or if you are representing a clinic, perhaps an independent clinic as part of the Oklahoma webinar series, we want to really encourage you to focus on data collection and reporting of quality measures, because today you are generally exempt. That's terrific. That will change over time. It may change quickly, and the change is going to bring with it a direct linkage to how you are paid. And so we want to underscore that. The last thing I'll share with you about our improvement model before I hand this off to Zach is that when we think about the finance node and how that generally breaks down into revenue and expense, our experience is, generally speaking, now, of course, there's always exceptions. Generally speaking, the biggest bang for your buck is not on the expense side, because so many organizations are already sort of at the bone in terms of running efficient operations. And most people on the call, I assume, have a business card with 2 or 3 different titles because you work in rural healthcare, which means you've got 5 different hats to wear. The bang for the buck is really on the revenue side and focusing on increasing volumes as we prepare for the inevitable transformation to true value-based care, of which CMS says they want to see the vast majority of their reimbursement be value-based by 2030. I'm not convinced they'll meet that deadline, but they have put a stake in the ground, and they have said within this decade, they want the majority of reimbursement based on value. And you've got regional consolidating health systems looking to build out at scale larger delivery systems. Geographically, the only place they really have left to grow is rural. And so for that, it means the critical access hospitals. But again, even more importantly, it's the alignment of those rural health clinics and the linkage to those hospitals that we're really focused on. And rural hospitals create a lot of value. It's understanding and being able to articulate that value as the consolidation process unfolds. And that's part of what Zach's going to talk about now, are those different facets and those different examples. So Zach, with that, we're at slide 6. If you can grab the control back from me.
Let's see. All right, so we should be able to pick up right where seamlessly Greg left off. So whether we are looking to collaborate regionally or, as we'll also talk about later on in the presentation, if we're looking to create defensibility around our hospital and better compete with other hospitals and systems within our regional service area, it's really important for us to be able to understand what our cost structure is. Now, we operate in an industry which is very labor and capital intensive, which means that we have an incredibly high fixed cost structure. And these are the things that, regardless of if we have 0 patients throughout the day, we are going to have these costs existing no matter what. Some of those are listed here below. And one of the things that we also know is that upwards of 90% of our cost as a hospital and as a critical access hospital that generally has lower volume, these are fixed. And so that means we have very little ability in longitude to be able to control our costs. Now, certainly, there are different things that we can do to go through and optimize services and create efficiencies and make sure that we're not just, creating cost for unnecessary reasons, but there's not all that much we can do from an operational standpoint to control our costs. And so, by contradictory to our fixed costs are our variable costs, which are relatively small. Like I said, they're generally 10% or less of our total cost structure. And these are some of the things that with each additional visit or patient day, it's costs that we're going to accrue, such as, individual, what's the cost of that next swing bed day? It's going to be the food, it's going to be the drugs, medical supplies, very small in comparison to our fixed costs. And so one of the levers that we're able to pull is by increasing our volume, our fixed costs are going to be diluted at a faster pace than our variable costs are growing. And so this is going to allow us to create efficiency within the services that we're offering and lower our per unit cost for all the different services as our volumes grow. And so, as an economic philosophy, really volume is the solver of all things. And it's important that even as a critical access hospital, that we have the same economic imperative as a PPS hospital. We receive cost-based reimbursement, and that's great. But even if we're 100% cost-based reimbursed, that's only ever going to allow us to break even. And over the long term, that break even is not a sustainable proposition. So it's really important for us to find different opportunities to create positive margin and profitability in order to continue maintaining the services that we currently provide, expanding services that we can get into, and maintaining our attractiveness to potential partners within our service area. So at right, we have a little graph here that shows, as revenue goes up and as volume goes up, we ultimately go from a loss position. Once we pass our fixed cost threshold, we see that our variable costs are increasing slightly as time goes on or as volumes go up to a point in which we reach profitability. So as I was saying, volume is our big solver for all of our economic woes and allows us to expand and become more attractive to other partners. But one of the things that I want to mention that I think is really important, and this seems very basic when you think about it, but only by increasing our volumes are we able to reduce our per unit cost. And we can only achieve profitability once our per unit cost drops below our reimbursement rates of commercial payers. Again, our cost-based payers are only ever going to pay us our cost. And so whether our cost is high or low, we're just going to receive that back. But it's our fixed fee reimbursement from commercial payers where we're going to be able to generate margin. And it's only until we're able to dilute those fixed costs and reduce our per unit cost below reimbursement for those commercial payers do we become profitable. So next is, talking a little bit about the triple aim. And in recent years, this has morphed really from the triple aim to the quadruple aim. But really just focusing on this triple aim is so that the United States healthcare system, we've realized over time that we are the costliest in the world and costliest by far. And so the Institute for Healthcare Improvement, put into a framework of the triple aim where we're looking to achieve three main principles of improving, patient experience of care. So that's patient satisfaction as well as specific quality scores. We want to improve the overall health of specific populations. And then we want to reduce the per capita cost for providing those services. And if you think about it, in a perfect world, yeah, that sounds great. Let's take care of all of the populations in which we serve. Let's have really high quality and patient experience. And let's do that at a price point that is manageable to help reduce the expanding rapidly of the healthcare costs overall in order to maintain sustainability going forward. And so the main areas in which the IHI triple aim looks to roll out this design is with a focus on individuals and families, redesigning primary care services, looking at overall population health management, controlling costs, and system integration. And from thinking about this as a perspective of regional collaboration, we really kind of can check all of those boxes as we go along. So next we will talk about that regional collaboration. And there's many different areas that we can focus on. And so we have, as we go through the next several slides, we're going to have an entity A and an entity B. And certainly if we're going to be collaborating with a partner, there's going to be a couple of different parties involved here. And I like to think of the critical access hospital as the entity A and the system or, larger partner effectively as the entity B. And so as a critical access hospital, if you look to partner with a larger system or some type of other partner, that there's going to be benefits for you as the CA, and there's going to be benefits for the system partner as well. And really, that's how it should work, right? We should be in a symbiotic relationship where everybody's benefiting in some degree. So first off is looking at the image and franchise. And so as a critical access hospital, if we come into a system relationship and we're using the name and kind of letting the system hang their shingle on our building, that we are being pulled into the image of that larger organization. We're getting branding and recognition for all of those different types of services that the larger system is providing, and we're taking benefit from that halo effect, so to speak. So again, I live in Maine. The largest system here is Maine Health, and so a individual independent critical access hospital that becomes part of Maine Health now has kind of the image of that entire system, and it is understood more by the patient populations that, okay, we are well aware of the system. We know that we can go there for all different types of services, and now this hospital is affiliated in some way with the system, and that is generally seen as a good thing overall. Now, for the entity B, or for the system in this case, looking at this from a franchise perspective is, now if we have another, we bring in a critical access hospital, we're able to expand the brand of, again, in that example, Maine Health, to different rural communities. And this will increase the reliance on the patient population. It will expand, the knowledge of patients on our brand overall, and we will be expanding the different service areas in which we have into these rural communities. And in a world where we continue to push for accountable care organizations and other population-based outcomes, expanding into these rural markets where Greg had mentioned that 1 in 5 people in the country live, this is going to increase the attributed lives to the larger system. And this is something that's going to be attractive as we move more toward those models. Next is looking at purchased and support services. And so this is going to allow critical access hospital access to things such as group purchasing organizations and other agreements that is able to reduce the cost for our critical access hospital. Now, you could, go in and try to purchase, however many widgets for critical access hospital, but if you had the scale of a larger partner or other hospitals as a system, that this is going to allow us to receive a preferential rate for the different things that we're purchasing. So if a system purchases 1 million widgets and we purchase 100,000 widgets, we could probably get a better price overall while working together when we purchase 1.1 million widgets, as an example. Additionally, for the larger system, and again, if the second entity is roughly the same size as the first entity, this is going to be an equal benefit. It's going to be the same type of thing that the critical access hospital will get. But as a larger system, when they have additional purchasing power, that allows them to also dilute down their fixed cost and leverage economies of scale. So as we mentioned about understanding your cost structure earlier on, this isn't just for us as critical access hospitals. This also goes for large systems as well, because they have the same high fixed cost structure that we have. So it's really important that they're also looking for opportunities to get a better price on some of these different things that they're purchasing all the time.
Zach, I would stress that the GPO angle is one that we're hearing more and more just in the last couple of years because of inflation. And so that becomes a very enticing option for a small rural hospital or even an independent rural health clinic out there operating on their lonesome. Being able to access some of the GPO rates is really pretty compelling. The other thing that we're seeing a little bit more of, and there was actually an article just this week where Oracle Cerner made a lot of inroads in rural America, and they lost a few accounts, but they netted out by adding a bunch of small rural hospitals, but they lost a lot of their they lost some of their urban hospitals, whereas Epic is sort of growing in terms of units of bed counts for the properties that are using their platform. And I think as you look out over the future, you'll continue to see increased consolidation and mergers and acquisitions, even of the EHR vendors. and they haven't quite figured out, well, they haven't figured out interoperability, but they haven't quite figured out how it's all going to play in terms of the major actors with EHRs yet in rural. It's still very much musical chairs.
Next, we look at service coordination and linkage. So for a critical access hospital, this allows us to be operating in an environment where our patients can secure services at other hospitals, other providers, other, if we have rural health clinics, for things that we don't provide in our rural community today. Now, as a CA, we can't be all things to all people and offer every service. It just, one, doesn't make sense because we don't have the demand, but we also don't have the ability to offer that from a cost perspective. And so it's important for us to have, if we're looking to collaborate with a larger entity, that we're able to provide certain services that we wouldn't be able to provide on our own. So maybe we have not the demand or aren't able to afford an orthopedic surgeon, but we can work with a regional partner to have an orthopedic surgeon come in for 1 day a week, as an example. So this is going to allow us to offer services that we weren't previously able to offer. And it's also going to decrease the number of patients that we lose due to follow-up opportunities because we don't have providers for them, the next step of referring them to an additional service. And so it allows us to increase the care coordination that we have within a system as well. And then for the entity B, for the system, it allows them to leverage their different hospitals and practice designations, making sure that patients are able to get the care that they need when they need it. So a perfect example of this would be, a larger tertiary acute care facility partnering with you as a critical access hospital, offering swing bed services. And they're able to develop a relationship with you where once they have acute patients that are ready for post-acute care, that they're referred to you for swing bed services. And that's going to reduce the wait list of patients that are ready to be then admitted at the acute care facility, that are able to bring a larger, DRG payment versus holding that patient in a bed because they don't have somewhere to discharge them to. So again, there's a very symbiotic relationship between a critical access hospital and a partner hospital or system in this example. And certainly will also allow for population-based initiatives where once we coordinate and link these services together, that the system's able to look at health outcomes of the entire patient population and monitor these things through the continuum of care to make sure that we're improving the outcome of the patient populations in which we serve, again, going back to the triple aim. Next is looking at shared governance. So similar to the purchase services that we discussed already, that management support is an opportunity for a critical access hospital. So this is something that we find pretty routinely when working with hospitals, is that we're not able to attract and keep all of the higher level experience and things that seem to be more specialized in our small communities. And it just, it's a fact that in a small community like those in which we serve, that next chief information officer is not growing on trees. And so it makes it very difficult, one, to attract them, but two, because we tend to be a bit smaller, we may not have a need for a full-time CIO, but we need the experience and expertise of a CIO. And so maybe this gives us an opportunity to work with a larger system and be able to buy some percentage of that CIO's time in order to help provide certain services that we need at a cost-effective price point. Now, similarly, on the other side for the system, this allows the larger system to provide certain services to a critical access hospital. And again, because they also have a considerable amount of fixed cost, that they're able to distribute some of that cost out to partners in critical access hospitals. So maybe they have, 5 CIOs that operate among 7 or 8 different hospitals, that they don't need a full-time person each one of those, but they can distribute that out as needed across all the different entities that are part of the system. Now, this also is beneficial from the standpoint of being able to push down overhead from a system partner to a critical access hospital, we know that there are certain financial pickups on the cost report aspect of things that will also kind of allow us to rinse and reuse certain percentage of cost that goes to us, because we're also reimbursed at our cost-based percentage overall for those costs that are pushed down to us. So rather than dollar for dollar coming over, the system pushes a dollar to us, but we're actually getting reimbursed on a percentage of that dollar, whatever our cost-based payer mix is. So it's actually costing the system less to provide those services. That is making, overall the critical access hospital providing a significant need at certain positions. Next is capital investment. So, I'm sure everyone on the call has experienced this in some way or another, but it's very difficult to receive, access to capital in many ways, and to be able to fund some of the things that we're looking to do in terms of facility replacements or a new wing on the hospital, or be able to purchase certain equipment, maybe a new CT scanner, MRI, that type of stuff. And being able to work with a system, that partner generally has the ability to fund certain capital initiatives. And that's going to allow us to, provide services that we currently provide in a better way, expand services that we maybe couldn't provide before. It's also going to reduce the capital cost and, our borrowing cost for us as a critical access hospital. I was working with a system in a smaller hospital where the weighted average cost of capital for the critical access hospital is about 9 or 10%. But they were working with a large system that had gone out to the bond market, and they had secured billions of dollars in debt at around 2% that the CA was able to tap into for future capital projects. And so just being able to lower the cost of borrowing is going to have a significant impact on the ability to provide these capital projects. And then switching over to the larger system entity, that it allows them, to take a regional approach on what the specific needs are for a given patient population. So we often have a lot of duplication of services in communities. We have underused staff. And when we take a system approach at things, we're able to kind of put resources where they need to be, when they need to be there. And it will allow for greater efficiency, which of course, we're always looking for greater efficiency, lowering our per unit cost. And it also allows them for centralizing certain services at rural hubs and being able to have the pulse on specific demand for services within a region. Next is technology integration. So for a critical access hospital, being able to be included on a larger system's EHR system or PACS or other performance improvement tools. These are things that maybe we wouldn't be able to afford on our own, or we wouldn't be able to get some of the nicer, more expensive tools that ideally we would like to have. Certainly will also help with interoperability. As Greg had mentioned earlier on, that is something that we're always looking to solve for. But if we happen to be on all the same systems as a regional partner, then that's going to eliminate a lot of those hurdles that we have in terms of interfacing and such. And then from the larger system partner, they have access to all of the data for patients that all of the outlying service areas in hospitals and clinics and such in which are part of the system. I believe it is the University of Iowa that allows any healthcare provider to join their Epic EHR system. So that's a great thing for the specific providers, since they have either a low or even no cost to be able to have access to a great system, and they're able to receive all of the data at the system level in order to help manage patient populations going forward in a better manner. Physician integration. So for a critical access hospital, this is going to allow us to have access to providers and certainly specialists that we're not able to get. So I touched on this a little bit earlier on, and allowing for oversight for advanced practice providers and supervision to work with physicians and such at our system that we would be, unable to attract or would be unsustainable for us to maintain due to volumes within our area. And then from the system perspective, looking at physician integration and physician deployment, that they're able to look at providers and get them away from the larger population urban centers, deploying them into rural communities, increasing access to some of those specialty services, reducing cost, but also bringing referrals back for more complex services back to the urban centers. So again, it's a way for them to increase their market share for certain specialty services, which we can't offer in our communities as critical access hospitals. And it allows them also to share costs among all the different affiliated hospitals in the network. Next is around clinical integration and integrated systems. So this is providing access to processes and evidence-based standards that the larger system has figured out, which is something that is more difficult for us as a critical access hospital, not having the resources and manpower, so to speak, to be able to monitor all this stuff. It's something that maybe we don't have. We don't have the people and the ability to monitor and maintain these systems, where a large health system may have an entire department focused only on this. And so this also allows our providers to rotate into larger hospitals, understanding, getting education on what is best practice and process and increasing certain competencies, but to then come back to our hospital and be able to, allow those things to proliferate throughout our organization. And then for the system perspective, it allows the creation of staffing pools, being able to deploy those as needed throughout the region and match when patients need care at the time of which they need it. And certainly we know that during COVID, we had a significant staffing shortage, which we're still seeing at this time. So it allows us extra capacity from the system as well. So some of these operational considerations are clinically integrated networks, looking at things such as team-based care, looking at quality improvement, care coordination, data sharing, increasing efficiency. All these things are incredibly important for our organization as well as the larger system. Additionally, looking at group purchasing. So looking at the things that we can purchase that is much cheaper as a system if we're able to bundle things. So looking at supplies, pharmaceuticals, being able to bundle employee benefits, or being able to be self-insured as part of a larger system. EHR, all these things are incredibly important for us to try to create efficiencies. It's for critical access hospital, but also for the system itself. And again, a very symbiotic relationship. Looking at the referral process internally within the system. So making sure that we have, structural integration in maybe shared space between the hospital and the system, having a fully integrated process as well. Single medical records. So if we're on the same EMR system, having, not having to go through all the process of issues with interoperability and interfacing and things that break, everything's very seamless and all together. Shared billing and scheduling systems as well. And then integrated care initiatives. And as we're thinking about working with a system, we want to make sure that, as we're going about this process, that we're focusing on the patient and making sure that all the decisions we make are patient-centered, and that we're not doing anything to compromise access to care, that we're expanding that access to care and making it as easy as possible for patients to receive care. Making sure that we're delivering the care where the patients want to be seen, that we're using evidence-based standards and other things as we're going about creating this process. So next, we'll talk a little bit about regional competition. So kind of shifting gears from collaboration to the competition aspect of things. One of the things that will ultimately bring greater competition for us is the change to the rural health clinic reimbursement methodology. Now, as we know, for hospitals with greater than 50 beds or independent rural health clinics, that prior to the Consolidated Appropriations Act, that the reimbursement rate for rural health clinics was around $84 per visit. And that was an unsustainable model for a system to get into the rural health clinic business. With the passage of the Consolidated Appropriations Act and knowing how those rates have jumped way up, for independent rural health clinics and for rural health clinics aligned under hospitals of greater than 50 beds, by 2028, the Medicare rate is going to be $190 per visit. Well, that's a much more compelling proposition for a larger system to get involved in the rural health clinic business. And so whether that is establishing the new rural health clinics or buying up independent practices and designating those as rural health clinics, there's margin to be made there. And anytime that there's margin to be made, you can bet that larger systems or other hospitals operating in our area are going to get into that business. And it's something that we need to be prepared for and be leveraging these rural health clinics as our own to play defense against that increased competition that surely will be coming. Additionally, we can look at the different practice designations as a way to increase our ability to defend against competition. So we have a bunch of different type of designations that we can be. We can be, aligned with FQHCs. We can have provider-based departments underneath our critical access hospital, provider-based rural health clinics under a hospital fewer than 50 beds as a critical access hospital, or the thing that we don't want to be ideally is a freestanding health clinic. So we have a bunch of benefits in order to increase our reimbursement and optimize that to the extent possible. Certainly legislation is always changing, because we know that with the Consolidated Appropriations Act. But if we have any freestanding health clinics, they're not able to tap into any of these benefits. And so is there an opportunity there to change the designation of a practice in order to increase the reimbursement received by that practice to allow us to better compete with other facilities in our area? Additionally, with practice alignment and designation, there's 4 main things that we can tap into to improve reimbursement for the practices that we have. So the first is, like I was saying on the previous slide, is converting practices to a designation that provides the most advantageous reimbursement opportunity. So if we have freestanding health clinics, looking to make that provider-based, looking to make it a rural health clinic, anything that will increase the reimbursement that we receive and make us better defensible against any competition within our area to increase the net position of our hospital and system. Additionally, looking to realign practices within a system to look at different reimbursement opportunities. So this was something that we saw a lot of prior to the Consolidated Appropriations Act, where we had large systems that had medical groups against essentially freestanding clinics, that if they were to convert those to rural health clinics and align those underneath critical access hospitals, there was an opportunity for a while to receive that uncapped cost-based reimbursement. Even still, it would still be an opportunity to convert those to rural health clinics, since those are going to be receiving greater reimbursement than any freestanding clinics that would be part of a medical group, as an example. Additionally, looking to find opportunities to integrate specialty practices and providers within provider-based departments. So, one of the ones that we're seeing quite a bit recently is integrating mental health within rural health clinics, and that will be even easier in the future as other practitioners are eligible to become rural health clinic providers. And then fourth, looking to acquire independent practices. So that I talked about this, really on the previous slide, is that we know that there's independent practices within the communities we serve, that if we can get those practices aligned with us, either acquiring them or developing contractual relationships such that we are able to designate them as some other designation, whether provider-based clinic, rural health clinic, being able to tap into other revenue opportunities such as the 340B program. Those are things that we want to do to play defense against competitors who would be entering our service area to directly compete against us and refer volume for certain hospital services out of our service area. And then related to that, the COD federal distance criteria changed last year on November 1st, and what CMS considered a primary road. So primary road is any road that is, 35 miles away from, or a COW must maintain at least 35 miles on primary roads from the next hospital, or in the case of mountainous terrain or only secondary roads, 15 miles, unless the critical access hospital was designated as a necessary provider before January 1st, 2006. So they wouldn't need to meet that distance criteria. Well, this was something that creates certain limitations for critical access hospitals, for hospitals that really need to be CAWs but aren't able to convert due to the distance criteria. And it limits the provider-based clinic establishment by critical access hospitals as well, because the distance criteria extends the hospital to wherever the clinic is. So if you were to establish a provider-based clinic, not rural health clinic, then you would also need to maintain the 35 miles on primary roads and 15 miles on secondary roads. So that changed in November 2022, that it used to be any federal highway, including interstates, intrastates, expressways, or numbered federal state highways. It was one lane in each direction. That was now changed to 2 lanes in each direction. So there's a lot of those numbered highways and expressways throughout the country that are just one lane. Some I've seen, there's one in upstate New York, kind of where I'm from, that it was really more of like a dirt road type of thing, but it was a state highway. And so that was considered a primary road. Well, this allowed a lot of the hospitals up there with this change, that now that it's 2 lanes in one direction, that they're eligible to convert to a critical access hospital to make themselves more competitive from a cost standpoint and reimbursement aspect against other hospitals in the area. It also allows for the establishment of off-campus provider-based departments, such as physical therapy or diagnostic treatment centers, having X-ray and lab and those types of other provider-based departments, that before we were kind of capped in by our 35 miles, where we're able to expand into some of the service areas, creating provider-based departments that maybe we couldn't have before. So again, there's a lot of changes that are always happening that will, if we're tapping into these different opportunities, making sure that from a competition standpoint, that we're able to better compete and, always be looking for things to increase our net financial position to be able to better compete with other organizations within the regions in which we are serving populations. So that is the end of our slide deck today. Are there any questions for Greg or myself?
Hi, Zach. I'm watching the chat. I don't see anything coming in yet. Everyone, you do have the opportunity to unmute your line if that'd be easier as well. All right. Well, not seeing any yet. Thank you both for your time today, and thank you for such a great presentation. Also, Greg, thank you for plugging the Rural Health Conference. For those of you who have attended in the past couple of years, it is the same location in Edmond at the new hotel off of Covell. You will be seeing more information from us as the agenda gets set and more details are finalized. But thank you all for your time, and thank you both, Zach and Greg. Everyone have a great day.
Thanks, Laura. Bye-bye.
Thanks, Laura. Bye.
Well.